see. We're good here? Okay, cool. All right, so let's go ahead and start with week 3 of the boot camp. All right, so we're gonna do a quick recap. So make sure y'all get that knowledge reviewed. Who can tell me what the PANTS stands for?
Physician Assistant National Certifying.
Yes. And then how many hours is the PANTS?
5 hours.
5 hours. How many questions total?
300 questions.
300, right? So 60 per section, and you have an hour pretty much to complete them. Good. All right. Now, which system or which specialty has the largest percentage of medical content on the PANTS?
Cardiovascular.
Yeah, so cardiology. Yep. All right, and just kind of shifting gears a little bit, talking about our review of systems. So why do we ask for a comprehensive review of systems with patients? Anybody got any ideas?
Isn't it just to get an overall view of how the patient is feeling in their own words?
Yeah, just the
Okay.
overall, some general health questions with regard to their overall health, right? This helps to, create that differential diagnoses, helps us to figure out if there are any red flag symptoms, things that might, allow us to, develop our line of questioning a little bit better, and organize our history taking as well, especially with some of the pertinent positives, right? All right. So we briefly talked about this. Blockage in which blood vessel is known as the widowmaker? In the heart.
Isn't it the LAD?
Yeah. And what does the LAD stand for?
I think it's left anterior descending artery.
Correct. Perfect. Yep. LAD. All right. So between these 3 patterns on an EKG, which one is a normal EKG? Which one's an NSTEMI? Which one's a STEMI? Let's start with this one on the left right here. What is that?
One's normal.
Normal. How about this middle one?
STEMI.
Okay. And then the one on the right?
Non-STEMI.
Okay, perfect. And then what differentiates them with regard to, say, for example, the middle one versus the third one?
The middle one has the ST elevation, whereas the right one has it descending.
Yeah. So it's more so, we have that ST segment elevation, right? And STEMI, sometimes it can be normal as well, but for the most part, if it's elevated, that there you have it for the STEMI. All right, perfect. So this is that cartoon that I was wanting to show y'all last week or last class, but what is this classification known as with regard to congestive heart failure or any type of heart failure? It's a state.
New York.
New York, right? New York Heart Association heart failure classification. So as you can see, just depending on, what the patient is presenting as, what they're able to do or what they're unable to do, especially with regard to activity. This is how we classify their heart failure. And then obviously, we dig deep a little bit deeper with regard to getting an echocardiogram, taking a look at their ejection fraction, the valvular structures of the heart, and other aspects as well that would allow us to, determine the treatment, whether it's implantable cardioverting defibrillator or just a pacemaker, more than likely just a pacemaker. All right. What is the main cause of ischemic heart disease? What's the main reason why patients get ischemic heart disease?
Atherosclerosis.
Exactly. Yep. And again, that builds up over time, when we're young, and then as we get older with the plaque buildup from diet, lack of exercise, lack of blood flow, other comorbid conditions such as diabetes, and especially smoking as well, right? All right, so can somebody read this pants question for me, and then can we talk about what the possible answer is?
I can read it.
All right, go ahead, Brendan.
A 43-year-old male with a past medical history of hyperlipidemia and a social history of smoking has been having recurrent episodes of episodic sharp chest pain that usually occurs after activity or first thing in the morning. The patient reports of sharp substernal pain currently and looks anxious. Chest radiology shows no acute cardiopulmonary disease. A 12-lead EKG shows ST depression and T-wave inversions. At 120 beats per minute, labs showed elevated troponin. Which of the following is the most likely diagnosis?
All right, thanks, Brendan. So who can read the diagnoses and let us know what your thoughts are with regard to the diagnosis, the most likely diagnosis?
I can read them.
All right, go ahead, Kayla.
A is acute pericarditis, B stable angina, C unstable angina, D Prinzmetal's angina, and E non-ST elevations myocardial infarction. Maybe I was thinking B. Yeah, it's between B and E. B I was thinking only because it says it's after activity or like first thing in the morning, but then after doing the EKG, it talks about the ST depressions and whatnot. So maybe I'm thinking more so E.
Okay. Anybody else have any thoughts? Thank you, Kayla. All right, so with regard to pants style questions, a lot of times some of the answers are going to look very similar. You can kind of make a case for either or, and a lot of times, it's more about reading those key clues within the past medical history and within this vignette and overall, right? So it being episodic and usually occurs after activity and first thing in the morning, so wouldn't really say it's timing wise where we can pinpoint to exactly what's going on. And I would say that helps differentiate between being stable versus unstable versus the myocardial infarction. The other thing is, say for example, if the EKG showed normal changes and no T-wave inversions, and the heart rate is within normal limits, between 60 and 100 beats per minute, I would say it's a little bit more stable angina, as opposed to an actual myocardial infarction. But with this, especially with the elevated troponin and the EKG and these symptoms, I would lean more towards E. So you're right, Kayla. It is a little tough with regard to trying to differentiate between B and E, but I would go with E. All right. So who can help read this question right?
I can read it. A 42-year-old male presents with acute chest pain for 2 hours that is not relieved with rest. On physical examination, his vital signs are as follows: blood pressure 88/60, pulse 49 beats per minute, respirations 20 per minute, O2 saturation 97% on room air, temperature 98.5 degrees Fahrenheit. An ECG shows 3 millimeters of ST elevations in leads 2, 3, and AVF, and ST depressions in leads 1, 2, 3, and 4. Which of the following is the most appropriate management at this time? Administration of IV nitroglycerin, administration of IV morphine, administration of IV fluids, administration of IV labetalol, and administration of IV furosemide.
Okay, perfect. Thank you, Maeve. So obviously we're going to be in more of an inpatient setting, right? Based on this, it seems like the patient is having myocardial infarction, but look at his vitals. He's looks pretty hemodynamically unstable. Blood pressure is pretty low. His pulse is low, so pretty much he's not really getting much out there in terms of blood flow. So let's just talk about some of these medications, right? So labetalol is a beta blocker, right? That's typically used to treat what? High blood pressure. Okay. So beta blockers used for treating blood pressure. Would we want to give that patient right here with the blood pressure of 88/60 labetalol?
No.
No, right? It's going to drop it down even lower. Aside from that, it also works as a rate control medication, and his heart rate is already low as is. Furosemide, which is Lasix. So if we give this patient Lasix and he's not even getting enough blood flow to the area of the rest of his body, essentially, we're going to deplete a lot of his volume, right? So we're going to be having him spill out a lot more. And so furosemide or Lasix is a diuretic, again, just to kind of get rid of the fluids. And so we don't want to do that. Morphine, yeah, we can definitely help with the pain, and the nitroglycerin can definitely help, but that would also drop his blood pressure. So the correct answer, most appropriate management right here would be IV fluids, just to kind of get him a little bit more hemodynamically stable. And we can recheck his blood pressure, recheck his pulse. If he's good, then we can get him ready for cath lab and or treat him with morphine and other aspects. But for right now, let's work on getting his fluids and on par with where he should be. All right. Any questions with either of those questions? All right. Oh yeah, go for it.
Really quickly, could you explain why E wasn't correct again? The administration of the IV furosemide.
Furosemide, yeah. So with Lasix, it's a diuretic, so it's going to drop his blood pressure down even more, and also he's already hemodynamically unstable, meaning he doesn't have enough volume. So with that, we're gonna get his fluid even more. So typically we would treat that with patients with CHF, or if they have lower extremity edema and swelling because they're in fluid overload. That's when we would give them Lasix or furosemide as a diuretic. Other than that, yeah, I wouldn't give it to him on this, especially with where he's at with the blood pressure and the pulse. All right.
Thank you.
Of course. All right, y'all. So enough of the hard stuff. We're going to talk about some PA resources that might be applicable to y'all in the next year or possibly next few years, just when you get into PA school. And this is just kind of based on my experience in terms of what I utilized and also what I've seen around, and just kind of, the material that we go through, but at the same time, the things that match up with the pants and just preparing for a PA school overall. All right, so this is my quote unquote honorable mentions. I did use both of these with regard to the med comic. So y'all saw that one comic with regard to the New York Heart Association classifications for heart failure. So that was the same author who wrote these med comic mnemonics and comics that allow you to help memorize different conditions, and then also interpreting EKG, just figuring out how things work like that. It's very, like, there's good information on there, but it's not in the depth of what to prepare. It's more of like a quick, like, okay, now I get it kind of thing, as opposed to really reading to understand the full capacity of it. All right, and then online med ed. So that was typically for med students. However, they created a PA aspect that allows you to do quick summaries of different conditions, as well as practice questions and online lecture videos. My qualm about this was it again was more towards medical students, so a lot of it didn't fully match up with PA school education, but for the most part, all of those topics were definitely discussed, and different algorithms in terms of workups and treatment, things like that. So these two are my honorable mentions for right now. Smarty Pants is a specific aspect for PA schools. This resource gives you, the different blueprints and every single condition and diagnosis, or condition and disease that's on the pants that you're expected to cover. However, is it in the full depth of it? Not necessarily. It's pretty, summarized in terms of the key buzzwords, the key diagnoses and etiologies that you quote unquote need to know, but not into the full depth and extent. I do like how they have practice questions on there as well. And they also have, it's very organized to where you can, go through everything. And you can do it in terms of like a practice pants exam, a practice end of rotation exam for emergency medicine, family medicine, things like that. And then you could also break it down with regard to the different modules as well. So this was pretty efficient, but this was not in as much depth from my experience. Yeah, so this is kind of what I was referring to with regard to the practice exams based on modules, comprehensive exams, and daily pan read questions. So price-wise is fairly inexpensive as well. And then Rosh Review. So we actually got this for free from our program. Obviously included in the tuition, but Rosh Review was the questions were a little bit more relevant and also on par with the PANTS exam. So some of the questions on here were pretty tough, but they overall encompassed everything that was required to know. And towards the end of PA school, especially during clinical rotations, I was doing a lot of Rosh Review questions. It was required for us as well, where we had to answer a certain amount of questions. But for the most part, we ran through all the questions and just practiced doing them over and over as well. All right, and then so they had a Rosh Rapid Review book as well. It's kind of the same way that it is presented in those other resources. So presentation on how the patients are presenting, what kind of symptoms they have, on physical exam, what you would find, different diagnostics, and then I like how a lot of them are bolded to where you need to know these things, or different pearls like associations and different contraindications, things like that. And there are some images and diagrams, but not to the extent of some of the other resources that we've talked about and that we will be talking about. All right, so this is kind of new. It was broken down into didactic year and clinical year. So I think they've definitely taken a lot of the suggestions and feedback from, when we were utilizing it and when previous students were utilizing it as well, and we're able to create something to where they have it down packed to where it's organized and very efficient for usage, regardless of what clinical year or regardless of what aspect of PA school you're in. All right, and then these are kind of a sample of the practice questions on there. They have a huge test bank, which is great, but as you can read it, vignettes that are similar to what we've already kind of talked about, as well as ones that are very similar to the PANCE exam, and they'll give you what you answered and what the correct answer is. Different. This is more so just analytics with regard to your strong suit and which ones you're weak in, and other aspects to keep you organized as well. This was pretty new. We didn't have this digital resource when we used Rosh Review. All right, so I didn't get a chance to utilize this too much because the PA who actually is running this platform and resource, he actually graduated the same year as me, so which it was pretty awesome that he was able to teach this extremely well and very efficiently. I really like it. If I had to do PA school over again, I would definitely utilize this resource right here. So this is Zach. So he's a PA, I think, out in New York or Philly. We graduated from PCOM, but I'm not sure exactly where he went after that. But he's explaining all these things. He has a team that goes through the different conditions and different pathologies and pathophysiology of different diseases, and very comprehensive, very in-depth, and he explains things extremely well. So I would throw this up on top as a great resource with regard to your PA school lectures. All right, and finally, Pants Prep Pearls, shout outs to him, Dwayne Williams, PA Williams, who created this thing. This is also known as the PA School Bible. So this is kind of a picture of how I utilized mine. So I would highlight the condition or disease in yellow, the etiology or the different type of bacteria or virus that's causing this condition in green, and then physical exam or clinical manifestations, I would highlight that in blue, and then management in pink, and then the diagnostics and the testing and stuff, I would do that in orange. So this was like early on before I got my system down packed, but essentially this is how I organized it, and I would highlight and go through these, and at the same time during PA school lectures I would write the notes on the side, so when it came down to studying for the board exam for the PANCE, everything was already right then and there, and I could just review it and go as is. All right, so this is PA Williams right here. Met him at AAPA in New Orleans as well as in Denver, and now he has different versions. I think he's on version 4 right now, but I had version 2. They have a question book as well, and yeah, another great resources. All right, so for tonight's lecture, we're going to just go through HPI a little bit more with practicing. So overall, there's 2 ways that you can take an HPI. One is old cards, as what we've discussed about before. So O is the onset of their symptoms, L is the location of their symptoms, their pain level, or their pain locations. Duration, is it chronic or acute? Has it been going on for weeks or months or just started this morning? Different characteristics of the pain. Is it dull, achy, sharp, burning, alleviating or aggravating factors? What makes it worse? What makes it better? Radiating or relieving factors, kind of interchangeable like that. Does it radiate down to their arm? Does it radiate down their legs? Does it radiate to the back of their shoulder? Things like that. And then timing wise, so is the pain constant? Is it intermittent? Do their symptoms occur intermittently, or is it always there? And then finally, severity. So I like to use the 1 through 10 scale for patients. So I'll let them know, I'll ask them, can you go ahead and rate your pain 0 to 10, 9 to 10 being you got to go to the ER. What would you say you're at? And I love when patients are like, before they say that, I'll ask them, pain scale 0 to 10. They'll give me a 9, and I'll ask them, okay, let's try it again. 1 through 10, 9 and 10 being you got to go to the ER. What would you say you're at? And then they would just change it to like 8.5 or an 8, even though you could tell that we've seen patients who should be at a 10 out of 10 pain, and they're fairly okay and fairly stable, especially even with a broken arm, things like that. But some patients that I either they don't have a good grasp and understanding of pain level, but at the same time, you still have to document what they tell you. All right. So another aspect that we can utilize instead of old carts is OPQRST. Essentially the same aspect. Onset, provocation, what makes it better or worse. Quality, this is where they would describe the pain in their own words. Radiation, does it spread anywhere? And severity, again, for 0 pain to 10 being the worst pain. And then timing wise, is it getting better with time? Is it getting worse with time? Is it unchanged over time? So you can't go wrong with either way, especially as a scribe and especially as a clinician when you're out practicing and documenting your notes. So you want to try to hit all of these components to make a thorough HPI, not necessarily for billing purposes, but so that way you have a full picture of what's going on with the patient in terms of treatment and all that. All right. So we're going to go ahead and practice. So I have a vignette and scenario in my computer right here. So I'm going to have y'all ask the question. So y'all can go ahead and take turns asking questions. So how would we start? Let's say I'm presenting with the 2-day history of cough and congestion in my nose. What do y'all want to ask?
When did it start?
I'll say it started on Friday morning.
And did it come out of nowhere? Did you notice it gradually come on?
I would say it's been gradual. It's been gradually worsening.
Have you tried any medications? If you did, what worked for you?
I tried Dayquil and NyQuil. Doesn't seem to help.
How would you describe the cough? Is there like any phlegm or any like mucus, and what color?
Yeah, I would say it's like a hacking cough, but I do have some like greenish yellow phlegm, but it's only first thing in the morning. David's asking here, any fevers? No fever.
Do you have any
just-
history of asthma or allergies?
I do have a history of both.
Is it environmental or food related?
More so seasonal allergies.
And what asthma type do you have?
Just childhood asthma. I think I've grown out of it, but I still have allergies.
Do you have any other symptoms?
Slight headache and a little bit of pressure in my face.
Do Do you have any dizziness or nausea?
No, none of those.
Is there anything that makes the coughing worse?
Nothing that I can think of that makes it worse. I would just say the cough is worse in the morning.
Is there anything that you're doing in the morning before your cough begins? Any activity?
No, just first thing in the morning when I wake up.
Any new products or foods that you're using?
No, nothing out of the ordinary.
Have you taken a COVID test?
I have. It was negative.
Has it been getting better, your cough? Or same?
It's about the same. Again, just mainly in the morning.
I don't know if this was asked already, but have you tried any allergy medication in the morning to see if that helps?
I have not yet. Okay, so David's saying would get vital signs, probably examine and all that too. Yeah, we can definitely get to that part. But any other questions with HPI? You know, what else do y'all want to ask me? Is there anything else that you need to know?
Does the coughing bring you any chest pain? I know you said it was a hacking cough.
No, just maybe a little irritation from the cough, but no true chest pain.
Okay.
And to answer your question, David, no pain, just pressure in my face and head. All right. Anybody else have any other questions that you want to ask? Y'all think you got a pretty good HPI? All right, who wants to give it a shot? Just present this HPI. Let's say my name is Mr. Hamilton and I'm 27.
I can try.
All right, go for it, Isha.
Okay, so 27-year-old male presents with cough and congestion that started 2 days ago. Patient states that it worsens in the morning and he sees green and yellow film. He denies, or actually, wait, hold on. Oh, he has a headache and pressure. He has a headache and also presents with pressure in the face. He denies a fever. Oh, it's kind of hard saying on the spot. I feel like I need to type it because I want to rearrange things. If I were to rearrange this, I would put the history in the first sentence, but patient has a history of asthma, childhood asthma, and seasonal allergies. Patient describes it as a hacking cough. Patient has not taken a COVID test, or patient has taken a COVID test and it came out negative. Yeah, I think that's everything.
Did you mention the medications? I didn't catch that.
Oh, right, yeah, okay. Patient has used Dayquil and NyQuil and neither has relieved the pain.
Okay. Sounds pretty good to me. Anybody else have anything to add? Good job, Isha.
I would probably add that the patient has not taken any asthma medication.
Yeah. I don't know if we asked about asthma medication. I think we asked about the allergy medication.
Or was it allergy? Yeah.
Allergy. Okay.
medication. Yeah.
Yeah. We could say that they haven't tried any, allergy medications. Okay, cool. I don't expect y'all to know this, but let's talk about some possible differentials, even though we didn't examine them or take any vitals. What are y'all's thoughts with regard to some differential diagnoses?
Sinus infection. Unlikely.
Okay. Cold, sinus infection. What else? Yeah. Exacerbation of allergies. We can say a little bit of like a allergic rhinitis, right? Um, Anybody think about possible strep? Yes or no?
No.
No, I wouldn't chalk up strep either. Just because with the cough, typically patients don't really present with a cough with strep, and they would have a fever. They would probably complain more about their throat, like sore throat and itchiness, as opposed to the nasal congestion. So the thing I was trying to get at with some of the questions that y'all asked, when I kept saying like my cough is worse in the morning, a lot of that is what postnasal drip, right? So from the back of our nose, drip into the back of our throat, irritates the back that oral pharynx region. So that mucus that drips down, especially when we're sleeping, a lot of times patients will cough at night, first thing in the morning because of that postnasal drip, and they think it's coming from the chest, but it's actually coming up from the upper respiratory tract. And a lot of times that cough gets worse just because they're utilizing their accessory muscles and chest muscles and all that. But I would do reassurance, listen to their heart and lungs, take the vitals, and lungs sound clear. I'd say, hey, I think everything is coming up from here. We could palpate the sinuses just to see if there's any tenderness to palpation over the maxillary and frontal sinuses. Um, if they had any mucus, we can take a look and see what the color is. Green, yellow, thick phlegm would be a little bit more indicator of a sinus infection for sure. All right. Great job. Good practice. Good teamwork, y'all. Let's take a quick like 2-3 minute break in case anybody needs to get some water, use the restroom, and then we'll hop right into ortho.
Hey Aaron, I was wondering if I can ask you something.
Yeah, go for it.
This is kind of like off topic. It's about the recording for the first session that we had. I was wondering if you can email it out to us because I asked someone else and they sent me the recording and it was the Monday recording you had sent to the Sunday group.
Oh, okay. My apologies. I'll definitely look into that after class. I should have had all the lectures uploaded. I'll double check and I'll send y'all another email with all of the lectures for this cohort for the Sundays.
Oh, okay. Thank you so much. I
Of
appreciate it.
course. Sure. All right. Are y'all ready to dive into ortho? All right. So for tonight's lecture, we're going to go ahead and talk about roles of ortho PAs, as well as, talk about the shoulder, especially with rotator cuff pathologies and issues. We're going to talk about the different components of the rotator cuff, the sits muscles, as well as special shoulder examinations of the shoulder. So I definitely want y'all to not know this like the back of your hand, but at the same time be familiar with it. When you get into your ortho lectures, you can be a little bit more familiar with it. I had a student from a local PA program that was rotating with the clinic that I was covering that day, and you know, I was a preceptor for that day essentially, and I asked the student, you know, to let me know what special shoulder exams they performed on the patient, and they couldn't tell me. And this was a second year PA student, so I don't want y'all to, you know, be in that position. When you go out into your rotations, you should know the special shoulder exams. Um, you should know it before coming out of didactic year. So again, no pressure to know it now, but at the same time, I want y'all to remember, hey, Aaron's gonna yell at me if I don't remember the shoulder exams during rotation. So just an FYI and a heads up. I'm not gonna name what program it was, but again, it was a local PA program. All right, so PA's roles in ortho, you know, they're part of that physician-led team. They practice in ortho, providing medical care under the orthopedic surgeon's supervision. There are some ortho docs who do not do surgery, and they mainly just work outpatient. Ortho PAs perform exams, interpret diagnostics such as X-rays, MRIs, CTs, ultrasounds, prescribe medications, and assist in ortho surgery with the surgeon, and then we're able to work in both inpatient and outpatient settings. Ortho surgeons will tell us, you know, to do pre-op exams, post-op exams, and you know, different aspects within that care team. And a lot of times they'll have that same autonomy. So sometimes they'll see patients, you know, on the same schedule as the orthodox, if it's in the outpatient setting, and or you know, take call with patients, you know, with the hospital whenever there's an ortho consult as well. All right. So aside from performing those comprehensive and problem-focused history and physical exams, again, we're able to interpret all the different diagnostics and do a full workup, implement therapeutic intervention, and you know, these are the other diagnostics that we were talking about. So we can do an electrocardiogram or you know, EMG and nerve conduction study just to check for any carpal tunnel issues, carpal tunnel or cubital tunnel issues, compartment pressure measurements for compartment syndrome, order x-rays, take a look at x-rays, different types of x-rays, and scans, including CTs, MRIs, and ultrasound and bone scans. All right. Now, aside from some of the procedures that we're assisting in surgery, we can do outpatient procedures such as digital blocks or local anesthesia, hardware removal, INDs, incisions and drainages, different K-wire removing, percutaneous pinning of fractures, tendon repair, wound repair, different things with regard to, you know, the musculoskeletal system. All right, we can also splint, cast, and apply braces to patients, reduce fractures and dislocations, inject shoulders, knees, elbows, aspirate different bursas if there's swelling and, you know, a lot of fluid within the joint as well as within the bursas, different trigger point injections and bursal injections, and tendon issues as well. We can, you know, help facilitate that treatment. All right, so again, assist in the surgery, medications, different orthotics and braces and orthopedic devices, you know, educating the patients and, you know, providing different resources and education throughout, even if it's not just in ortho, but just, you know, with smoking cessation, diet and exercise, things like that. And then, you know, doing post-op rounds and writing orders and discharging patients or admitting patients as well. All right. So here is the shoulder girdle and region. So we have the clavicle, we have the humerus, the arm bone, and the scapula. So these three essentially make up the shoulder girdle. So these are the terms that I want y'all to know. With regard to a sprain, they are stretched or torn ligaments, and we typically grade sprains and strains in 3 different grades: grade 1, grade 2, and then grade 3. Grade 3 is like a full tear, full rupture. On MRI reports, a lot of times we'll see, partial tear or fraying or, things like that to indicate a lower grade, or they'll say full thickness rupture, full thickness tear, things like that. So sprains are torn or stretched out ligaments, while strains are stretched or torn muscles and tendons. Okay, so the difference between the two: ligaments are fibrous tissues that connect, 2 or more bones at a joint, right? So our ACL, our anterior cruciate ligament, connect our femur as well as our tibia. Tendons, on the other hand, are the fibrous tissues that connect the muscle to the bone itself. So, which we're going to talk about right now with regard to the rotator cuff tendons and rotator cuff muscles. So, you can strain a tendon, you can strain a muscle. Sprains, they're ligaments that you sprain. All right. So, again, basic anatomy of the shoulder. We have the AC joint. Okay, the acromioclavicular joint. So this is the acromion right here. This is the clavicle. And right in there, it's combined by ligaments. The glenohumeral joint, this is the GH joint right here. So this is the right behind this humerus is the glenoid space. So there's a labral joint, labral socket in which this ball of the humerus, the head of the humerus, inserts into. So the shoulder is a ball and joint socket joint. And so the humerus here, these are the 4 rotator cuff muscles, or the sits muscles, that I want y'all to remember: supraspinatus, infraspinatus, teres minor, and subscapularis. So all of these, we're going to go into the origin and insertion of them, but as you can see, they help move the shoulder and stabilize the shoulder girdle. All right. So the supraspinatus, infraspinatus, subscapularis, and teres minor. The origin right here on the scapula. All right. So the supraspinous fossa, the infraspinous fossa, and the subscapular fossa. And then the teres minor comes down here on the lateral border of the scapula. And they all insert right at the humerus. So supraspinatus, subscapularis, and infraspinatus all attached to the greater tubercle, or that head of the humerus, while the teres minor inserts into the lower aspect of the humerus, lesser tubercle of the humerus. All right, and these are the different rotations and movements that allow us to move the shoulder in so many different directions. So the supraspinatus is responsible for abduction, which is lifting your arm up to the sides. Infraspinatus, so lateral rotation. Infraspinatus, so subscapularis, is medial rotation, going in, and then infraspinatus going out with that lateral rotation. And then teres minor also helps with that lateral rotation and adduction, so going into us, right? So abduction is like you're being abducted out, and then adduction, you're adding into us. All right. So again, elevates the shoulder joint out to the side when you were lifting up, so that's abduction. Infraspinatus externally rotates the shoulder joint. Teres minor also helps to externally rotate, so that lateral rotation, right? And then the subscapularis helps us with the medial. All right. So with regard to shoulder exams, first thing we're going to look at, we're going to inspect, right? So first we're going to view. We're going to look for any deformities, look for any changes to the skin, any muscle atrophy, or any bony abnormalities. Is there an apparent fracture? We're going to look for any asymmetry, or is their shoulder drooping to one side or another? We're going to compare both sides, okay? And then second, we're going to go in and palpate. So we're going to go and palpate that AC joint, that acromioclavicular joint, just to make sure it's not sprained or, widening. And then we're going to go ahead and palpate the biceps tendon to make sure that there's no defect right there, what we call a Popeye deformity. That would be an indicator of a proximal bicep tendon rupture, or sometimes we'll have a distal bicep tendon rupture in which the biceps gets retracted either proximally or distally. And then the coracoid process, we'll kind of palpate that as well, make sure there's no tenderness in that region, and the subacromial space. That's typically where the bursas are as well. So a lot of times different shoulder pathology can mimic each other just because, as I tell patients, as you can imagine, there's so many components in such a small space. Anytime there's some type of swelling or inflammation, it's going to go ahead and aggravate and, irritate that region as well. All right. So next, we're going to talk about the different ranges of motion and strengths of the rotator cuff muscles. So we're going to do a, different, what we call a painful arc test to have them lift up their arm and see at what direction or what degree they're going to have that pain. If they have pain at a certain arc, that would be a positive painful arc test. The drop arm is while they're slowly lowering their arm. And then when they drop their arm, that's an indicator of a supraspinatus pathology. And then empty can test, so they're going to kind of empty out a can in front of them or to the side, and we're going to push down on it, and they're going to try to resist that. And then, as we mentioned, the infraspinatus and teres minor, those help with external rotation. And then subscapularis, internal rotation. So we're going to go ahead and do what we call an Apley's scratch test or a Gerber liftoff test. And they're going to kind of put their arm back behind them and then push out against it, or just to see how far they can reach. Okay. Excuse me about that. Next, we have the biceps test. A lot of times this is to check for flexion or supination of the biceps to make sure there's no bicep tendon pathology, and to make sure that there's no tear as well. Next, impingement. So this is just to make sure that there's nothing getting stuck in the way, right? So the Neers test and Hawkins test are the two main tests to check for impingement of the rotator cuff. So the Neers test, you're having the patient lift up their arm near their ear. So that's how you remember that, right? So Neers test is forward flexion near their ear. And then Hawkins, you're kind of moving their arm with the forward flexion and then internally rotating it like it's a hawk. So the arm is moving up and down like a hawk. So the AC test to check for the acromioclavicular region and the joint is a AC scarp test where they reach across, or a cross arm test. And a lot of times patients will say ow or have some type of pain and impingement in that region as well. And then finally, stability. So we're checking to make sure that there's no labral tear of their glenoid humeral joint. Make sure there's no feeling of their shoulder giving out, right? So this is checking for stability. All right. Rotator cuff impingement, as we mentioned right here, for the Neers and Hawkins test. It's when the rotator cuff becomes pinched underneath the acromion. Something feels like it's getting stuck and they have to kind of like move it out of the way. And then a rotator cuff tear is, like I said, tear of one of the tendons or the muscle itself. Different causes could be with overuse, pitchers, quarterbacks, people who, different jobs and occupations that require them to repeatedly overuse their shoulder, degeneration. a stat that one of our ortho docs told me was, about 60% of patients over the age of 60 are going to have some type of degenerative rotator cuff injury, and obviously trauma. So with the fall, stretching out and having their shoulder, bent backwards, things like that. Direct trauma to it if somebody gets hit. If it's strong enough, it can potentially cause a tear as well. So that leads us into this case study right here for Mr. Davis. So I'm going to go ahead and have somebody read this beginning case study, please.
I can read it. Mr. Davis is a 33-year-old male. His date of injury is April 13th, 2024, and his chief complaint is that he cannot lift his right arm above his head.
All right, cool. So we have Mr. Davis, 39-year-old male, got injured a few days ago, and chief complaint, right arm pain, right? So can't lift right arm above my head. All right, so next for the chief complaint and the pertinent positives and negatives for the ROS.
I can do it. So we have Mr. Davis, a 39-year-old male. The date of injury is April 13th, 2024. His chief complaint was, I was playing catch with my son and now I can't reach above my head. For the review of systems, the pertinent negatives are weight loss, fever, chills, nausea, headaches, nausea, vomiting, chest pain, shortness of breath, urinary incontinence, numbing, tingling, weakness, and extremities. And then the pertinent positives are joint pain and decreased range of motion.
My apologies. I was supposed to take out that nausea. I didn't catch that again. Thank you. All right. Who can go ahead and read us the right side of the slide, please?
I can do that. So for his pain, he's describing it at an 8 out of 10. He's saying it's constantly achy and intermittently sharp, unable to sleep on his right shoulder, worse with movement, better with rest. And for the treatment, he's tried an ice pack, biofreeze, and 100 milligrams of ibuprofen.
Perfect. All right. Thank you, ladies. So let's go ahead and have somebody try to create an HPI for us. I'll leave the slide up so somebody can create it. All right, who wants to give it a shot?
I can try.
Go ahead, Brendan.
Yeah, so Mr. Davis is a 39-year-old male who presents with right shoulder pain. He states his date of injury was on 4/13/2024. His injury was from playing catch with his son. Currently, his pain is at a level of 8 out of 10. It's constantly achy and intermittently sharp. His pain is better with rest, worse with movement. He's also unable to sleep on his right shoulder. So far, he's tried a couple of treatments, ice pack, biofreeze, and 800 milligrams of ibuprofen. He also states that he has joint pain and also decreased range of motion.
Okay. And then anything else anybody want to add for Brendan?
Oh, and he can't lift above his head. I'm not sure if I said that.
Okay. I think you might have mentioned that, but yeah, good HPI. I think we got all our, components that we need. Let's go ahead and examine him. So let's have somebody read this general physical exam, and then we'll go into the more focused musculoskeletal exam.
I can read it. So general alert oriented ×3, mild acute distress, head, atraumatic, normocephalic, eyes, extraocular motors intact, perla, ENT normal hearing, skin dry normal, pulmonary normal, respiratory effort, lungs clear to auscultation bilaterally, nervous, normal gait, reflexes intact, CV, regular rate and rhythm, no murmurs, rups or gallops, psych, slow speech, normal mood and judgment.
Okay. And now let's go ahead and focus on the shoulder.
I can read that part.
All right, go ahead,
So,
Sarah.
his left shoulder, normal appearance, full active range of motion, passive range of motion, no tenderness to palpitation, over AC joint, biceps tendon, coracoid or
Subacromial.
subacromial space negative, Yersin's, painful arc, AC crossover, Nears, Hawkins test, a Paley scratch test, 5 out of 5 grip strength. For his right shoulder, normal appearance, no
Ecchymosis, which is bruising.
ecchymosis,
Mhm.
no swelling, no deformities, limited active range of motion, limited passive range of motion, secondary to pain, tenderness to palpitation, over glenohumeral joint, posterior shoulder, subacromial space, no TTP over biceps tendon, corticoid or subacromial space, negative Yersin's speed test, positive painful arc, AC crossover, Nears test, Hawkins test, and LP scratch test, and 4 out of 5 grip strength.
Okay, cool. So a couple things on there for the right shoulder. Again, so it looks fairly normal. We don't see any deformities to think that there's like a dislocation or any major bruising or swelling. He does have that limited range of motion, both actively and passively. He has that tenderness palpation over the glenohumeral joint, so that GH joint, where the humerus and the glenoid spaces, posterior shoulder, so right in the back, and as well as the subacromial space, so right on the inside of that shoulder right there. So special test wise, we have a positive painful arc test. So again, if he's abducting and then at a certain degree angle, he's experiencing some pain. The AC crossover, so where he's reaching across, and the Nears test where we're checking for impingement, as well as the Hawkins test, we're checking for impingement. That one's going up for the Nears test, and then 90 degrees and forward flexion and internally rotating for the Hawkins test. And then the Apley scratch test is where he reaches back behind. And then, just based on the pain and everything, he has a little bit of weaker grip strength. All right. So diagnostics, what do we want to order? What do we want to check out and see?
MRI,
Okay. What do we want to start off with first, though?
probably X-ray.
X-ray. So let's go ahead and start with an X-ray. Say we get an X-ray, comes back normal, good joint spacing, maybe a little bit of degenerative changes, but good joint spacing. Then what else do we want to take a look at? So now we would probably do the MRI, right? With or without contrast. The difference just depends on what we're going to be looking for. If we're looking more of like a labral tear, I would go more with the with contrast just to show that a little bit easier. But typically with a basic MRI without contrast, we can see, rotator cuff tears if there is one. So let's say we get this X-ray, looks normal, right? But this MRI shows a torn tendon of the rotator cuff. So this right here is that space of retraction. So we would diagnose this as like a full thickness rotator cuff tear of the tendon, rotator cuff tendon tear, with X amount of millimeters of retraction. So this would probably go into surgery. But we would like to start with some physical therapy and conservative treatment just because we want to get that range of motion. We want to try to, strengthen the rest of the shoulder girdle while we're waiting to, do the surgery and get authorization on the surgery or wait for the swelling to go down, things like that, right? So a lot of times they don't go straight right into surgery. So, we'll continue with the NSAIDs, the 800 ibuprofen that he was already taking. We can try like a topical diclofenac sodium if he's already taking too much oral NSAIDs, continuing the ice packs for swelling and inflammation, resting. So, if he has a job, we would tell him not to do any overhead reaching or throwing or heavy lifting. At home or with his kids, not to do any throwing as well. Physical therapy, right? So just again, to improve that range of motion and strengthen the other shoulder components. We could try a shoulder injection, but that's not going to fully fix the problem of rotator cuff tear. And then finally, surgical intervention, whether it's an open repair or an arthroscopic repair, which is more common. So even after the surgery, we would probably still do even more physical therapy, just again to rehab that shoulder back into trying to get it as close to 100% as possible. All right. Any questions with regard to that case study?
In regards to surgical intervention, what would you typically do?
What do you mean?
Like, how do you repair it?
So you would pull the rotator. Okay, so rotator cuff repairs are where they pull, the retracted part of the tendon and muscle, put an anchor down, pretty much, drill a hole in the humerus and anchor it to where they can pull and sew the tendon and attach it together. It's not going to be full strength, but essentially that's how a rotator cuff repair works, generally speaking. There's different components to it. Sometimes they, if the shoulder's pretty bad, they might just do a full shoulder replacement. But a lot of times with rotator cuff tears, then they'll just do a quick repair.
Cool, thank you.
All right. Any other questions with regard to this case study? All right, perfect. So second to last topic of tonight, we're going to be going through some PA school buzzwords. So kind of what I was alluding to with a lot of those different resources, a lot of buzzwords pop up during PA school, and this helps us to kind of I guess just to be able to draw that comparison and draw that relationship between like a specific buzzword that you hear and a specific diagnosis or treatment. Sometimes it can be with regard to a physical exam finding. Sometimes it could be with regard to a condition or medication or different treatment. So we're going to go through a few of these. So whenever you hear a Scotty dog sign or a bamboo spine, when patients present that they couldn't cover their toes with bed sheets, on a radiology report, if you see like a onion skin or sunburst, moth-eaten tumor, these are different components. Especially when you read on a vignette, you already kind of know, boom, that disease or condition is X, Y, and Z. So for the first one, it's going to be a pars interarticularis defect. I'll show you on X-ray what that looks like. For bamboo spines, that's ankylosing spondylitis. It's a typical lumbar spine condition, but it could affect the whole back, mainly in men and young men as well. When they quote unquote can't cover their toes with their bed sheets because it's so painful, it's typically related to gout. And again, on that radiology report, on the X-ray, if you see like an onion skin or sunburst appearance, typically talking about a a bone tumor, bone cancer, Ewing sarcoma. All right. So this is that pars interarticularis defect. It looks like a little Scotty dog on the cervical X-ray. I don't see it, but I only see it after they highlight and outline it, to be honest. I've never seen this in real life, but you'll definitely come across this on like a pants question or an ortho question as well. All right, so the ankylosing spondylitis, you'll kind of see the spine where it looks, like a bamboo spine. Um, it's typically a lot closer together, so that joint spacing is less and less, and it's mainly just treated with conservative treatment and activity changes, things like that. All right, gout right here. So this is an extreme case of gout. A lot of times it doesn't affect the bone like this, and you won't get that big of swelling, but this is a pretty severe gouty flare-up. And patients typically get it in that first MTP joint, that metatarsal joint of their big toe. Sometimes they can get gout in their knees and their elbows and fingers, but mostly in the toes where, like I said, they can't sleep without without pain with the bed sheets touching it. All right, so this is kind of that onion skin or sunburst or moth-eaten tumor appearance. So that Ewing sarcoma. And sometimes you won't even see the x-rays. You'll just kind of read it on the vignette, and it'll say like 20-year-old patient presents with 3-month history of arm pain, and on x-ray you'll see a humerus with a moth-eaten appearance, something like that, and then that's how you kind of know the buzzword is that moth-eaten or the onion skin, relating to that Ewing sarcoma. All right, so these are a few more, also related to ortho. So the unhappy triad, obviously there's 3 components to it. So in PA school and in medicine, there's going to be a lot of like triads, pentads, and things that happen in multiple, I guess, not even just conditions, sometimes just uh, symptoms as well. But we also have like the atopy or allergic triad. So a lot of patients who come in with eczema, asthma, and allergies, that's kind of the atopy triad. But we'll talk about the unhappy triad right here with regards to ortho. The 6 Ps, there's also another condition that has like 5 Ps or the 6 Ps as well. But this one would be like pain out of proportion, paresthesia, pallor, pretty much like loss of blood flow and skin color, paralysis, so numbness and pulselessness. They're not able to get blood flow to that area, and poikilothermia, so they might have a change in that temperature of that area as well. Another condition would be where patients complain about having a pebble in their shoe when they're walking. And then finally, housemaid's knee. That's also another condition which you'll see for ortho patients. So the unhappy triad consists of an ACL or anterior cruciate ligament, MCL, medial collateral ligament, and meniscus tear. So if a patient has all 3 of that, that's an unhappy triad. And then compartment syndrome, patients will complain about these 6 Ps. So pain out of proportion, it's extremely painful. They have numbness, they have tingling, they can't feel their, below where they're getting hurt, and changes in temperature as well. So this is typically with a long bone fracture or some type of trauma to where the different compartments are swollen and it's cutting off blood supply and circulation, and compressing on the nerves as well. And then for patients complaining with the sensation of a pebble in their shoe, that's typically associated with a Morton's neuroma. And it's mainly in women who wear heels on a daily basis, or just throughout their whole entire life. And then housemaid's knee is prepatellar bursitis. So we'll go ahead and talk about that and how we get that. So again, unhappy triad, the ACL, MCL, and meniscus tears. So this is the MCL right here. The ACL is the one that comes anteriorly, and then the medial meniscus is on this medial side. This is very common in soccer players, sometimes basketball players, but mainly soccer players. And then this is the compartment syndrome. So again, so this is the normal compartment, right? So we have the bone, so the bone's right here. And then inside the compartment, we have the muscles, the nerves, and the blood vessels. However, if there's trauma to this, bone or different compartments, there's an increase in the pressure, and it's kind of compressing on all the different aspects of the compartments, which leads to tissue damage and lack of oxygen, and the patient can lose their leg. So again, any type of extremity trauma that causes that pressure buildup, and so they're going to need to do an acute compartment syndrome surgery. And with this, they have to relieve the pressure within the different compartments. So it doesn't even have to be just trauma, but it could be, say, for example, you're cutting off circulation in, a cast or a boot, right? Or even just an allergic reaction to, a bee sting, things like that can cause different acute compartment syndromes. All right, and that Morton's neuroma. So they're going to have that swelling and inflammation of one of the nerves, especially in the bottom of the foot. So again, it feels like there's a pebble in their shoe when they're walking, but there's nothing in there, and it's that irritation of that neuroma. So this is that nerve pathway, and if there's continued irritation, that causes that severe pain and numbness. And lastly, that prepatellar bursitis. So in all of our joints, we'll have some type of fluid-filled sac called bursas. And when the bursas get inflamed, especially with housemaids where they're constantly on their knee, scrubbing the floors and, cleaning, things like that, you'll get that bursitis where that prepatella is. So hence the name housemaid's knee, because this was the occupation that typically developed it mostly. All right. Any questions with regard to those buzzwords that we covered? All right, cool. So last topic for tonight, as we kind of alluded to earlier, we're winding down the time for this program, but at the same time, we're getting close to CASPA application cycle, especially for y'all who are applying, right? And even if you're not applying, or even if you're a reapplicant, I want to talk about changing your mindset and mentality. Some of y'all might, be steps ahead and already have this positive mindset and mentality, but for me, myself, it took a little while to develop, especially after my first year applying. So I think I might have mentioned this story to some of y'all in maybe might have been one of my posts in the past, or even like a shadowing opportunity. After my first cycle applying, what I did was, I didn't get any buzz from any program. I didn't get any interviews. And so what I did was I printed out a list of all my rejections, like every single rejection letter. I printed it all out and put it on a poster board. And I put it next to my bed. Every morning I woke up and I saw that thing, and it would motivate me to be like, all right, well, I'm going to get after it. I'm going to show these programs. I'm going to, keep working and keep hustling hard. And for me, especially as, a former athlete, that was kind of, your mentality, how you went about it. Right. Just kind of as a outside source of motivation and inspiration to, just go, do what you need to do. However, there was one time where one of my aunts was visiting, and she saw it in my room, and she was like, "Why do you have this poster of all your rejections on the wall?" And I was, explaining to her, because she knew I was trying to get into PA school and stuff like that. And I was explaining to her, like, you know, I just wanted to, motivate me, especially first thing in the morning when I see it. And she's like, "Why do you have that negative energy around you first thing in the morning? This is the first thing that you see. You're going to have like this negative mindset and mentality." And, I told her, I was like, well, it was a way for me to be motivated and inspired because, I felt like I had to, show these programs or like, I have to reapply again and stuff like that. But she helped change that negative aspect and really hone in on having a more positive mindset. And so I took off that poster board and, threw away not just those rejections, but also threw away that, negative mentality and mindset. And instead of seeing it as, damn, I have to reapply and be a reapplicant and I have to do X, Y, and Z and I have to take these classes and I have to do whatever. Instead, I changed that. I was reminded from football during high school, instead of having that have to mentality, changing it into a get to mentality, right? So instead of saying like, oh, I have to, take X, Y, and Z classes to reapply, or I have to wait a whole nother year, or I have to work this low end paying patient care experience job, is more of, all right, I get to have this opportunity to improve myself for this next cycle. I get to have this opportunity to build a stronger foundation for didactic year. I get to have these other patient care experiences in which I can build a stronger clinical foundation or patient interaction foundation, right? So instead of feeling sorry for myself and feeling like, damn, I have to do this, it's more like, all right, wow, I get the opportunity to do these things. Okay. So I definitely want y'all to remember that, especially when it comes to reapplying, or when it comes to applying for the first time, or having to, quote unquote, having to take these classes, the prereqs and all the hours that y'all have to get. All of us have to do it, but it's about your mentality and how you're, perceiving these different obstacles. Okay. So I know it's tough, and I get, uh, you know, there's going to be some times where y'all want to give up and you don't feel like you have the energy or mental capacity to get through this, but I promise it'll all be worth it. And again, I hope you can try to shift your mentality if you haven't done so already, to see what opportunities lie. All right. All right, y'all. So that's all I have for tonight. I will definitely send y'all an email with all the lectures so far on our video links. And yeah, any other questions for tonight before we end?